class. This is Mrs. O'Shaughnessy, and I'm going to provide you lectures for next week's class time on Tuesday and Wednesday. We're going to start out with the respiratory system, and as you can see by the screen, I'm going to talk about ABGs. But first of all, I just want to kind of give you an overview of the respiratory system. I have to say that this is probably the most important system that we're going to talk about in Nursing 210, because we all know that all cells and tissues need O2 to live and function. And some cells, such as the brain and the heart, are very, very dependent on oxygen. And without oxygen to these particular organs, especially the brain, it will stop functioning and die in about 5 to 10 minutes. Now we have other organs such as the skin, and they can live at very low levels or even without oxygen. And the brain and the heart really becomes very dependent on oxygen. And we as nurses, this is probably one of the most important assessments that we make on our patients, to observe, to visualize, and then to further assess how well our patient's respiratory system is working and how well they're being oxygenated. And many of the patients that we care for that are admitted into the hospital will have a particular diagnosis that does affect their respiratory status. And many times associated with respiratory problems or other problems, the patient will have comorbidities such as electrolyte and fluid imbalances. And that's why it's very important that you take a look at the PowerPoints that I provided regarding acid-base balance and regarding fluid and electrolyte imbalance, because I can't go over each of those PowerPoints in detail, but they will serve you as an excellent source as we, continue to learn and immerse in about all the systems that we're going to talk about with this course, that many of the patients who have problems with the respiratory, the cardiac, the hematological system, the endocrine system, diabetes, and of course the renal system will all have at some degree problems with fluid and with electrolytes. Okay, they're going to be very imbalanced. The fluid problem may not necessarily be fluid overload, but we can see patients develop problems with dehydration and underhydrated, which can cause serious problems and definitely affect blood pressure as well as respiratory status. And of course, when we have fluid problems, we have shifting of electrolytes in and out of cells, and we know which cells should be in this. What electrolyte should be in the cells and what electrolyte should be, out in the interstitial spaces or in the extracellular fluids. So, we have to really take this system very, very seriously, and because without a patient who is not oxygenating properly, this could put them in serious peril, causing them to, have oxygenation problems, which could eventually cause the patient to die. So this system is huge. We need to continuously assess our patients' respiratory status, and as we provide interventions not only by ourselves as nurses, but when the physician comes in to care for a patient and he is writing orders to hopefully improve that respiratory status, we again as nurses are constantly assessing, are these interventions working? And those could be anywhere from medications or oxygen therapy or respiratory treatments or outside mechanical assistance with ventilation. So we have to determine if these are improving our patient status. You know, are we seeing better patient outcomes because of the interventions we as nurses and as the healthcare provider orders for our patient, okay? And I think it's important to kind of think of the respiratory system not only about just the lungs, but about all the other ancillary structures that are involved in respiration, in oxygenation, you know, the upper airways, you know, things that may impair airflow could cause our patients to have respiratory problems. It's pretty obvious that with the respiratory system, probably the main reason for that system is for the purpose of breathing, to provide our bodies with the much needed oxygen for all living tissues and cells, and also to remove CO2, because we know CO2 is a byproduct where we have exchange of oxygen and carbon dioxide, which happens in the alveoli, where we have what we call a diffusion of gases. And another purpose of the respiratory system is the influences on our acid-base balance, okay? And of course, as an excretory system also. And so that leads us to this very short discussion on ABGs. We as nurses cannot draw ABGs, but we as nurses need to understand what situation may occur with our patients that we would see ABGs ordered. And there can be various reasons. Sometimes it's a change in the patient's status. Sometimes it's to assess if a certain oxygen modality is working for our patients. You know, maybe we had the patient on specs and then we're going to put them on a mask. Has that improved their PaO2? And we as nurses need to interpret these results, you know, to determine if our patient's in a alkalotic or acidotic condition, and to see if the primary problem is because of a respiratory problem or is it because of a metabolic problem. And then we know that when it, for instance, is a respiratory problem, that the opposite system, such as the renal system, would be the ones to kind of intervene and start making those corrections to hopefully bring that pH back to a normal range. And so, and we call that, you know, is it compensated, partially compensated, or no compensation at all? So that's where I'm just going to, you know, bring some discussion, you know, regarding arterial blood gases. You know, the ideal situation for anyone is, you know, promotion of health, kind of assessing that patients have no respiratory issues, and being able to detect and determine when that situation may change from a normal respiratory status to someone who's now developing signs and symptoms of respiratory disorders, okay? And as I said before, each structure and part of the respiratory system is so important to maintain proper oxygenation. Upper airways, lower airway structures, the lungs, the alveoli, the chest, the thorax region, and things like that. And this may be a good time for you as nursing students to kind of get back in and review some of the normal anatomy of the respiratory system, kind of remembering where the structures are and what function they serve us, you know, in order to properly, you know, oxygenate and, you know, keep all living tissues and cells within a homeostasis and a healthy abundance of oxygen. So everything kind of functions and operates the way it should. There's a lot of things to consider when we talk about the respiratory system. The physiology of ventilation, the expansion and contraction, the respiratory pressures, compliance, alveoli ventilation. And think about, too, the neurologic control, those respiratory centers in our brains, the chemical controls that affect our respiratory status and affect, how fast and how slow we breathe. And then, of course, ventilation versus perfusion. And it's also good to keep in mind, too, that, this system works very closely with the cardiac system, because obviously the heart is responsible for pumping and perfusing that oxygenated blood to all the different areas in our body. And then in conjunction with the hematology system, we have those particular cells called red blood cells that are carrying that oxygen to all the different tissues and cells in the body. So you kind of got to think about all three of those systems working, as we would call the buddy system, to keep everything in check. The respiratory system to provide the oxygen, the cardiac system to pump that oxygen throughout the body, and then the hematology system to provide the proper amount and also a healthy red blood cell that is able to carry that oxygen to all living cells and tissues in the human body. Okay, so that's kind of a little bit of a preface of the respiratory system. And, you will notice as you become more experienced in the clinical setting that, when maybe we have issues with the cardiac system, or we have issues with the hematology system in regards to cell count, particularly red blood cells. Maybe you have a patient who has a lower H&H. You will see some compromise in the respiratory system, okay? And so when, that happens, we're going to see our patients maybe even experience and demonstrate abnormal arterial blood gases, okay? So let's just go through this PowerPoint, and I hope it makes sense to you. And like I said, arterial blood gases will be a very important part of what we do as nurses in regards to determining when these should be done on our patients, and also the interpretation end of it, knowing what's exactly going on with our patients, okay? And many times we'll see a patient who may not be doing very well, that you'll see various blood gases drawn on these patients. So it's not seen that these patients will have it maybe done once, but if we do not see the kind of outcomes that we would like to when we intervene, if we notice that the patient is having respiratory difficulties, these may be done, every couple hours, or whenever we change some type of intervention to determine, what's the best way to better oxygenate this patient because of what his probably primary diagnosis is. So with that said, obviously the definition of arterial blood gas is a test that measures the levels of oxygen and carbon dioxide in the blood to determine how well the lungs are working. So that's very much of a simple definition. And we know that, as I said before, that process of diffusion of gases takes place in those alveoli. So remember, those are those little air sacs at the end of the bronchioles where the process of diffusion of gases takes place. They kind of look like little grapes. And within that, we have red blood cells in the capillaries. And so anytime we do any type of a procedure on our patients, obviously proper identification, explain to the patient And remember, this is an arterial sample of blood, so it's under high pressure. So usually this is done by a respiratory therapist, and usually they'll use either the radial or brachial artery to locate that point of pulsation. And, you've got to understand and take in consideration sometimes when these are being done that many times it can be very difficult to find that pulse, especially if we have a patient who might have a very low blood pressure. Maybe they have a very weak pulse, or maybe they're dehydrated, or, their vascular volume is kind of compromised. And before they actually take that specimen of arterial blood, they may do what we call an Allen test. And the next couple slides will show you what that is. Usually the radial artery is the first choice, and this is how the Allen test is done. They'll have the patient clench their fists to occlude the radial and ulnar arteries with their fingers, and after the hand pales, they'll have the patient open their hand and remove their finger from the ulnar artery while continuing to occlude the radial artery. Why is this done? This is done to just assure that if something would happen and compromise the radial artery, which obviously supplies blood to the hand, that if something would happen during the stick, that it's always great to know that the ulnar artery will take over and supply blood to that hand and not cause any problems with oxygen insufficiency. And so if the hand peaks up within 15 seconds after release of the ulnar artery, then circulation to the hand is pretty accurate. So that's why they do the Allen test. So the ABGs kind of are very closely related to our pulse ox, and that's pretty much the assessment tool we use when we do our vital signs and take our patient's temperature. We'll also do a pulse ox. And the pulse ox measures the percentage of hemoglobin that is saturated with oxygen, and we call that the SaO2. And it's equivalent to the PaO2 on the ABG results. And we like to see that level at anywhere between 80 to 100. And this just talks about oxygen in comparison to the SaO2 on the pulse ox as compared to the PaO2 with the hemoglobin. I mean, not the hemoglobin, but with the arterial blood gases. And of course, arterial blood gases has to do with the pH of arterial blood. And remember, if you go back to some of your chemistry, and this also is in the PowerPoints that I provided for you, it's based on that hydrogen ion concentration. So if we have more hydrogen ions, then we're going to have more of a lower pH, causing the patient to have more of an acidic condition. If there's a decrease in hydrogen ions, then we're going to have higher pH, causing the patient to be more in the alkalotic range. And the pH, as you can see from this PowerPoint slide, is 7.3 to 7.45. And the one thing I do want to stress with that is, if you think about it, that's a very, very narrow range. So, it makes sense to understand that when our patients have some of the very serious and complex medical problems and diagnoses that they have, that you can understand why that pH kind of starts to go out of range, and our patients either become acidotic or alkalotic due to a respiratory or a metabolic problem. And we know the one system called the kidneys can help adjust pH by bicarbonate, HCO3, and that's regulated by the kidneys. And whenever we see a abnormal bicarb being the primary problem, then it's pretty much considered a metabolic disturbance. And anything below 22 is acidotic, anything above 26 is alkalotic. And I'm sorry, that alkalotic is spelled incorrectly. And usually the range is 22 to 26, sometimes it's 22 to 28, it just depends on the source. Carbon dioxide, on the other hand, is more of the acid. This is regulated by the lungs. So anytime we see an abnormal carbon dioxide level, it pretty much is determined that it is a respiratory disturbance. The normal range is 35 to 45, and anything below that is alkalotic, anything above that is acidotic, okay? Kind of the opposite the way the bicarb works. And the reason we get very concerned about acidosis or alkalosis is the fact that this very much affects our patients systemically, okay? Too much acid or lost, too much base from the body. And when that pH starts to get really low, around 6.8, it really becomes incompatible with life. And the reason we are concerned is because of the effects of acidosis on the heart, vascular response, how it interferes with medication, and causes vasodilatation of blood vessels. So, that is, our concern. And many times when our patients do have some kind of acidotic issue, we'll see those snowballing effects on the cardiac system. And then alkalosis is anything over, a pH is, over 7.45, and anything over 7.8 is also incompatible with life. And this is where a person accumulates too much base or they lose too much acid, okay? And again, effects of alkalosis, interferes with tissue oxygenation, vasoconstricts, breathing becomes slow and shallow, okay? And the defense mechanisms, we have built-in buffers, and buffers can become depleted, which result in deficits. And then we think about compensation to get that pH to a normal range, either by the opposite system that's not causing the initial problem. Kidneys or lungs will attempt to maintain homeostasis. And the word compensation, when we're talking about ABGs, refers to that physiological response to minimize those pH changes, to really keep that range in that normal area, 7.35 to 7.45. And the primary disorder may continue, but that opposite system begins to adjust. And so if the primary problem is repaired, all the acid-base parameters return to normal. And that can be caused by any physiological or therapeutic response. And these are all the 4 different conditions that can occur when we see the results of someone's blood gases, respiratory acidosis. I'm not going to read these to you, but obviously this is probably one of the most common situations we see where somebody has a problem with their respiratory system, with their lung function, might retain CO2, and these are the various reasons why that may happen. And how your patient will manifest, how will they demonstrate when they do have respiratory acidosis. Pretty much an accumulation of CO2. And this is how we would treat that, and I won't get into that. And the same goes with respiratory alkalosis. We have a low PaCO2, probably a range below 35. Remember, the normal is 35 to 45. Causes, manifestations, and how we would treat it. The same goes for metabolic acidosis. DKA, or diabetic ketoacidosis, is probably one of the main problems that we see happen as to why someone would become metabolically acidotic. And we'll talk about that later on with diabetes, along with renal failure, lactic acidosis, starvation, aspirin overdose, diarrhea, and excessive acids. These are what your patients would definitely demonstrate. And definitely Kussmaul breathing is something we see in our diabetic patients who do go into DKA. And this is how we would treat it. And of course, metabolic alkalosis, where someone maybe has very serious vomiting and emesis, where they're bringing up all their gastric juices and gastric acids, can cause them to be metabolically alkalotic. These are what our patients would demonstrate, and again, treatments for that. So I won't go into this, but I have downloaded in Cabin some practice problems. I'm also going to upload a ABG case study so that you can get comfortable and familiar with solving and interpreting ABG results, okay? ROAM is just an acronym we use we're talking about a respiratory problem. So if the pH is low, which would constitute an acidotic problem, then we're going to see the CO2 climb, because the higher the CO2, the more acidotic the patient is. But with metabolic, it's equal. So if the pH goes up, meaning the patient is more alkalotic, then we're going to see the bicarb go up too. So they kind of go in the same direction. Whereas with respiratory issues, it's in the opposite. So that's what Rome means: respiratory opposite, metabolic equal. And these are just practice problems, and you might want to be able to do these and then determine if the patient has no compensation, partially compensated, or full compensation. And always remember, when we're determining if the patient does have full compensation, the pH must be normal, okay? So right away, if you don't have a normal pH, you definitely do not have full compensation with your arterial blood gases. So that's pretty much just a little short review of ABGs, because obviously the respiratory system plays such a huge part in regulating arterial pH and CO2 levels and oxygen levels. We will revisit this again when we talk about the renal system as our last system in the course. So I would hope that you guys would work on these, and really, if there's any questions in week 2 when we meet face to face, I'd be glad to do a couple problems on the board. And if people are still having problems, I'd be happy to meet with them, and just kind of go over things of maybe what areas are giving any of you the most problems. You really have to look at this, and you really have to understand what's happening. And it's very important that we as nurses are able to interpret these results, so we can kind of assess and apply some of the principles of the interventions, and know why we're doing that if our patients are alkalotic or acidotic. And then I think to always think ahead. You've got somebody that has an NG in, and maybe it's draining a lot of excessive NG drainage. That person would be at risk for an alkalotic state, because of the fact that you're pulling all that GI contents out of the body, and the patients are losing a lot of those acids from the stomach. So that's the kind of mentality we need to have, always thinking ahead about what could be a potential problem because of what's happening right now with our patients. Okay? Very good. All right, so we're going to begin now assessment of the respiratory system. All right, I'm going to go through this fairly quickly. It's really important that you read over this chapter because you've got to understand the foundation of how the respiratory system works, and it'll make more sense when we talk about some of the pathologies, especially with things like asthma, COPD, pneumonia, and then as we continue to assess our patients with these problems, when we find certain abnormalities with the assessment skills, then we can interpret what those mean in regards to our patient's condition. Obviously, this is just a slide showing the balance of oxygen intake, oxygen delivery, and again, oxygen delivery by red blood cells, along with the heart, helping with the active perfusion. I've already talked about what the purpose of the respiratory system is. Makes sense. And again, this is why I'm saying, we just can't think of the respiratory system as just about the lungs and the alveoli, but we're talking about structures of the upper respiratory system. And we will touch upon just lightly some of the problems our patients may have that you'll never see in the hospital, because if they have, sinusitis or deviated septum, it's not a serious enough problem to bring them into the hospital, but it is a situation that could interfere later on with, their respiratory status, okay? And again, just a few slides on the review of the anatomy and physiology of the respiratory system, looking at a little bit of a detailed picture about a cross-section of the alveoli and how those diffusion across that capillary membrane happen. And then on the right, just looking at, the crude picture of the lungs and the trachea, and how the ribs are in front of the thorax, and the rib muscles, and the bronchus and the bronchiole, and then the alveoli. And really considering how important the diaphragm is when we're talking about breathing. Because some of our patients, we may assess them and say, hey, they're diaphragmatic breathers. And then you see where the lungs sit in proximity to the heart. Okay, so I just kind of wanted to refresh your memory on that. And again, looking at the upper airway, and again, the lungs and the rib cage, and all the other associated structures, the epiglottis, the apex of the lung, which is in the top part of the lung, the carina, which is an important landmark, especially if we talk about intubation or putting a artificial airway in our patients, trachea, to better, oxygenate our patients. And again, how it works in proximity of the cardiac system. Okay, and we'll get into all that when we talk about the heart. All right. Just trying to get this slide more centered for you. Okay. So again, functions of the respiratory system. I don't need to go over that. This all makes a lot of sense. O2 transport, respiration, ventilation, and gas exchange. Causes of increased air resistance, sometimes contraction of the bronchial smooth muscle and the bronchioles, which can cause bronchial constriction, causing your patients to have, less of an area for the intake of oxygen, which we see very often in our patients who have like an asthma attack. Thinking of bronchial mucus in chronic bronchitis, obstruction of the airway by anything such as mucus, tumor, or foreign body, and then the lack of lung elasticity, as we see in patients who have emphysema. And again, just a little A&P review just to kind of go over the different structures when we talk about the upper respiratory tract. And remember how important, the nose and sinuses are, because that is where we take in that first breath of atmospheric air to hopefully reach the lungs and the alveoli, where we have that exchange of gases occur. And remember, think about the sinuses and the purpose of those. These are the paranasal sinuses. Thinking about the pharynx and the larynx, because anytime we have problems with that, we may see a compromise in the respiratory system. And these are just anterior and posterior view of the trachea and other surrounding structures. And of course, the lower respiratory tract, airways, and the lungs, and the airways consist of the bronchiole, the bronchioles, the alveoli ducts, and the alveoli, and then the lungs. And don't forget, too, when we talk about the lungs, that pleural space, because that's very important, and keep that in mind when we discuss about patients that might have issues with the pleural space. There should be a little of fluid in there to kind of prevent friction, but sometimes we see accumulation of pleural fluid, and our patients may have, again, a compromise in their respiratory status. And this, again, is the alveoli and the capillaries. And remember, too, when we talk about the structures of the lung, remember on that right side, we have 3 lobes as opposed to 2 lobes on the left side, okay? And then to talk about the accessory muscles with breathing, okay? Don't forget that Breathing occurs through changes in the size of and pressure within the chest cavity, and you have contraction and relaxation of specific chest muscles, and the diaphragm cause changes in the size and pressure of the chest. And when we talk about the accessory muscles, we're talking about like the scalene, the sternocleidomastoid, the trapezius, and the pectoralis muscles. Also, sometimes we see our patients use their back and abdominal muscles in the work of trying to breathe, and that may be more increased. Sometimes our patients who have end-stage respiratory disease or emphysema, you'll see them really using those accessory muscles to really get that breath in and hopefully try to get about their breath out. So, just wanted to kind of give you that visual picture of what may occur. And then, of course, with every system, as you're going to see, we're going to talk about what happens with aging in the respiratory system. Many times the heredity and exposure to substances that are in the environment, such as smoke, bacteria, air pollutants, and industrial fumes and contaminants, will affect how someone's lung function is as they begin to age. And don't forget that with our respiratory system, respiratory disease is the major cause of illness and chronic disability in older patients. These are the various structures within the respiratory system that will be affected by aging. Alveoli surface, vital capacity decreases, residual volume increases. Muscles atrophy in the pharynx and larynx, pulmonary blood flow decreases, more intolerant to exercise. Muscle strength, especially the diaphragm, decreases, and effectiveness of the cilia decreases, making the patient more prone to infection. That's why as people get older, they're more prone to bronchitis, respiratory infections, because these cilia are these little hair-like structures that kind of push away those pathogens or organisms that try to get into the respiratory system. And so when those are decreased and less effective, those organisms or bacteria or whatever may lodge in the lungs, causing the patient to get some type of infection. And that's why it's always recommended that anybody 65 or older get that pneumonia shot, okay, because of just what happens as we age. More prone to infection. Thorax becomes shorter. And these are also many of the age-related changes in regards to the, the defense mechanisms. Decreased cilia, decreased cough and gag reflex. That's why we see a lot of people end up aspirating and sometimes getting aspiration pneumonia. Loss of surface area of capillary membrane, so we have a little bit of a decrease of those diffusion of gases. The lungs, decreased size of airway, chest walls and muscles, and then other kinds of associated issues occur with those particular structures. Risk for respiratory disease is obviously if you smoke, but it's definitely going to put you in harm's way to be more prone to infections and things like that, and even emphysema, which is the primary cause of why people get COPD, or even more chances of some of the lung cancers that we see. So these are all the other risks. And then we talk about those terms: dyspnea, cough, sputum, chest pain, and really what is their significance, okay? We talk about dyspnea, and that's just a fancy word for like shortness of breath. But remember, your book does talk about it, a certain type of scale. We look at how dyspneic are these patients, Are they very dyspneic? Are they dyspneic at rest? Or are they dyspneic, walking, half a mile? Do they have a cough? Do they have sputum? I'm not going to go into a lot of detail on that, but cough is a quite significant assessment findings. You want to know why the patient is coughing. There's some kind of irritation. I always learn cough as the watchdog of the respiratory system. And then sputum, is that cough productive, non-productive? Is it an acute cough? Has it just started, or has it been a chronic cough for your patient? And sputum is quite significant because, as I mentioned on an earlier slide, sputum can actually be an obstruction if it's thick enough, and copious amounts can cause an obstruction, really blocking that air from getting in and obviously CO2 out. So these are very, very significant findings on our patients, and sometimes that color of sputum can really signify what the problem is. Is it colorless? Is it red? Is it yellow? Is it green? It really, is it rusty color? Many of those can signify what kind of problems your patient's having. And a lot of times with respiratory problems, they can develop chest pain. So we have to kind of evaluate that more closely to determine if this is a pain related to a respiratory problem, or is this something that is a cardiac issue, or is it musculoskeletal, or is it more of a GI problem where the patient has, GERDs or heartburn or whatever. So those are things that we definitely want to look into further if your patient does demonstrate these manifestations. I'm not going to get into a lot of the history. I think you can read these yourself, but you can see what significant findings really would alert you to the fact that your patients may develop or have a serious respiratory issue, okay? And obviously smoking is huge. Drug use, allergies, nutritional status. Sometimes foods have a lot of preservatives, which people can become very sensitive to or develop certain types of allergies, okay? And as I said before, cough, sputum production, chest pain, dyspnea, PND, or orthopnea. These are terms that I want to make sure that you understand. We've already talked about cough and sputum production and chest pain, but when we talk about dyspnea, these are other important findings to kind of assess with your patient, determining what brought it on, how long does it last, and are there any relieving factors. And then PND is what we call paroxysmal nocturnal dyspnea, where you have intermittent dyspnea during sleep. Usually patients are laying flat, and many times they have respiratory and cardiac issues, and that fluid starts to build up in the lungs. And what happens is they kind of start becoming very dyspneic and kind of almost choke to death and have to sit up on the side of the bed. And then once that fluid starts draining down, taking it back, down to their, lower extremities, that dyspnea will start to subside probably within 10 to 20 minutes. Orthopnea is just that shortness of breath while laying down, but many times people that have chronic respiratory problems will sleep many times in a chair, just have their head of the bed elevated, and we see this with patients who have chronic lung diseases or patients who have left-sided heart failure. So that's the difference between orthopnea and PND. And again, we look at the physical assessment findings with our patients in the respiratory system. We think about assessing the nose and the sinuses. Then we assess the pharynx, trachea, and larynx. Do we see any history associated with these problems? And then, of course, the assessment of the lungs and thorax. As I said before, patients who definitely have dyspnea, we definitely want to rate that dyspnea according to a dyspnea classification from 1 to 5. And your book talks about that particular type of classification because many times dyspnea will interfere with our patients' activities of daily living. Maybe some of them can only do very simple tasks and not be able to do more of the strenuous type of task. And then we think about auscultation. And that is, again, part of our assessment findings, always listening to our patient's lung anteriorly as well as posteriorly, looking for what we call ventitious sounds, which are the normal sounds, the bronchiotubular, the bronchiovesicular, and the vesicular type of breath sounds. The ones that we're probably going to see most, because our patients have been admitted to the hospitals or the acute care settings, are the adventitious, which is just a fancy word for abnormal breath sounds. And this is kind of how we, listen to those breath sounds. We start in that left upper lobe and go from side to side and listen to all areas of the lungs, starting up at the apex down in the lower lobes. And when we hear a patient have an adventitious breath sound, it can indicate that our patients may have a problem or some kind of pathological change. So we may hear such things as crackles or rails or wheezes or rhonchi, whether or not it's inspiratory or expiratory. Sometimes our patients develop pleural rubs, stridor, crackles. Sometimes we don't hear breath sounds very good. They could be what we call diminished or even absent. Wheezes, usually we see with inflammation where those bronchioles start to constrict, that airway becomes very narrowed, a lot of edema. Patients may have a lot of secretions. Rhonchi, again, sputum, maybe an obstruction by a foreign body. And sometimes our patients may develop a pleural fiction rubs caused by pleurisy. Okay. So again, just a kind of a refresher and a review about how we auscultate those lungs. Other indicators of respiratory inadequacy: clubbing, weight loss, unevenly developed muscle, skin and mucous membrane changes, pallor, and cyanosis. Let's face it, looking at someone who has any type of respiratory diseases, we know that their general appearance is not really a healthy appearance. Many of them have loss of muscle mass. A lot of them don't eat well anymore. And without that good, strong muscle development, a lot of them have issues with their respiratory efforts. Okay. Endurance. Assess shortness of breath at rest or with any type of activity. And don't forget, too, that with the physical problems that are associated with respiratory issues, don't forget about the psychosocial assessment. A lot of these respiratory problems can be worsened by stress, and chronic respiratory diseases may cause changes in family roles, social isolation. Many people who have really advanced respiratory problems may have to retire early or may not be able to work and support their families. So they might have to go on disability or unemployment. And if they're young, this could be a very difficult situation to cope with. So we want to offer them and reach out to them and provide community resources to be able to cope with these unfortunate situations. I want to talk a little bit about laboratory testing. And we've already discussed ABGs, but all your patients, when they come into the acute care setting, they'll have some chemistries done and a CBC and DIF, and we'll be looking at red blood cells because, as I mentioned earlier, that's a very important cell, which is that cell that carries oxygen. Again, sputum. If your patient is having a lot of coughing, bringing up a lot of sputum, you might want to just get a specimen, send it down so we can definitely identify organisms or any abnormal cells. All patients usually have a chest x-ray when they come in. Those may be repeated frequently depending on what the reason is your patient came in, but sometimes we'll repeat those chest x-rays on a daily order because we're looking for improvements, or is the patient staying the same depending on what kind of interventions we're providing that patient. Is their respiratory status improving? They could also, and the chest x-ray serves a lot of important purposes. It can, diagnose such things as, pneumonia, atelectasis, pneumothorax, even tumors. So, and a lot of times we use a chest x-ray to assess for placement of, central lines. We'll do a chest x-ray to look at placement of endotubes if a patient's maybe been involved in a code blue. Is that endotube in the right spot? Because it needs to be able to ventilate both lungs properly. Many times, too, you'll see further diagnostics done with CTs, MRIs. Fluoroscopy is done a lot of times if they're doing invasive testing like fluorescentesis, or maybe even a lung biopsy, because with a fluoroscopy, they can actually see the exact location of where they're going with that needle insertion, so we don't nick any big blood vessel and cause, trauma or bleeding to that site. Pulmonary angiograms, lung scans, determining if our patients might have a pulmonary emboli. Again, we would do that with ventilation and perfusion scanning. And we know what the importance of pulse oximetry is to identify hemoglobin saturation, okay? And we really like it above 93 or above, and anything below 86, or even 90, we start to assess what could be the reason, and we want to make sure that it's effectively working and that there's no barriers to cause us to get false readings. Anything below 70 is definitely life-threatening. And then pulmonary function testing is a very important type of diagnostic where it is really intensive and really provides a lot of helpful information to really give us a great idea of how the lungs are working. They use this test when they're going to diagnose asthma. The patient preparation is what you need to know about, and that's what you have to think about as a nurse. When these patients are having these diagnostic testing, you may not know a lot about them, but the thing that you need to know is, what is my responsibility as the patient's nurse in preparing my patient for this test so I get the best results. And with pulmonary function test, sometimes it can be done with exercises to determine a lung or a cardiac problem. As I said, it's very extensive, and they do take in consideration a patient's age, gender, race, height, weight, and whether or not they smoke. And sometimes they'll do them as a guide to treatment or assess a patient before they're having surgery to kind of have an idea what their respiratory status is. Because think about it, if it's a long surgery, they're going to be under anesthesia a long time, and they want to know if their respiratory status or their lungs can handle it. Maybe they'll do it too to determine what our patient's dyspnea is caused from or why they're so short of breath. The important thing that you need to know is there's usually no smoking 6 to 8 hours before the test. They'll withhold certain drugs such as bronchodilators, and when the test is done, if the patient can go through all that, we'll sit down with the patient and go over what the results were, because like I said, they can get a lot of great information from a pulmonary function test. And then there's exercise testing, which what the goal here is to increase the patient's metabolism and kind of look at, how much, how gas transport is occurring, and, because, obviously if the patient is exercising, he's using more energy and is requiring more oxygen. And this can be done to assess a patient's ability to work and perform their activities of daily living. They can use anything from a treadmill to a bicycle. They might have the patient walk for about 12 minutes and closely monitor the patient. And let the patient know, too, that they're on a cardiac monitor and that they're really being watched continuously. And then, of course, skin tests, which you're familiar with, is the TB test. And looking at some of the viral diseases such as mono and mumps, and maybe certain allergies that may cause respiratory responses to determine, what is the cause or the organism that's causing that type of allergic reaction. So that concludes that part of the assessment. I'll stop right here, and then I'll continue with some of the endoscopic exams.